this neuromas expands of internal auditory canal, and with groomant can expand in the posterior fossa and cerebropontine angle, and to irritate the cochlear, facial, and trigeminal nerves, and then is enlarge could compress the brainstem. According to the size, neuromas classifies small, medium, and large. And when the small one is localized in the intracanaliculary and then expands in the posterior fossa in cerebropontine angle cistern. Medium, you see that tumors is larger and compress and irritate the trigeminal nerve and also acoustic nerve, and little bit stretch the facial nerve. And large neuromas could compress not only this fifth, eighth, and seventh nerve, but also the brainstem, and could develop the hydrocephalus because compressing of fourth ventricle. What treatments are available now? No, surgery is the common method, and it depends on age, patient general health, cardiovascular diseases, etc., hearing status, and of course the tumor size. After literature, in 40 till 50% of patients, tumor growth or progression of symptoms will prompt the need for surgery. Small tumors without or with some few symptoms, especially in older patients, in these cases, better to observe these patients with MRI in half or 1 year. And we see the progressing of this tumor and signs. That's we are thinking about the treatment. Stereotactic radiotherapy and surgery is nowadays is a alternative and serious alternative for microsurgery against maxillary surgery, and of course in selected patients. About surgery, priorities in surgery are the maintenance of facial nerve function, the preservation of socially useful hearing in the affected area, and the main goal is, of course, the complete removal of the tumor. While total tumor removal may result in a cure, also carries a higher risk of hearing and also the facial nerve damage during the exploration and removing of the tumor. And for preservation of the facial nerve, the facial nerve monitoring has been used during surgery, and this could give the better results, but not in all cases preserve nerve damage. About methods of surgery. There are three main methods for open surgery. The middle fossa approach through the subtemporal craniotomy. And this method is useful for small tumors and for preserving hearing. And the next is a translabyrinthine approach. That is approach through the air. And this approach has been used when the patient has absolute hearing loss on this air. And mostly suboccipital retrosigmoidal posterior fossa approach has been used. And this approach is good for removal all sizes of tumors, to inspect trigeminal and caudal nerves and facial nerve as well. And this method is good for all sizes of tumors. That's my personal case. That is tumors, medium-sized tumors, cystic Schwannoma tumor, patient with decreasing of hearing, tinnitus, and without facial signs. And the approach is retrosigmoidal suboccipital to this pontocerebral angle. And here you see the tumor. The tumor before resection, the tumor, one part is intracanalicularis. This is opened the canalicular part, and here is a tumor resected with preservation of facial and hearing nerve. Every open surgery has a risk. A risk is, of course, this general anesthesia, risk of surgery themselves, and risk of intra-hospital infection. Every patient have to stay in the ICU approximately 1-2 days in ICU, and approximately 1 week in the hospital. And in this period, during the surgery and afterwards, can observe the complications of the surgery, complications that includes facial nerve paralysis or paralysis, CSF fluid leak, and headache, meningitis, aseptic or bacterial meningitis, hemorrhage, and stroke, etc. And after literature, functional hearing preserving achieved in 48 of small tumors and in 25% of cases of medium tumors after surgery. And hearing was not preserved in any of the patients with large tumors in whom hearing preservation was attempted, of course, during surgery. Outcomes. Outcomes of surgery depends of the size and adherence of tumors, the use of cranial nerve monitoring, the skill of the surgeon and team of the surgical team, Of course, the small and medium-sized tumors for neurosurgeons is better case. And rates of success of postoperative hearing preservation and facial function, nerve function are inversely related to tumor size. And delayed hearing loss may occur after surgery in 30 to 50% of patients who had hearing immediately after surgery. And partial removing technique have higher rates of hearing and facial function preservation immediately after surgery, but had a threefold higher rate of tumor regrowth, recurrence of tumors, and a long-term impact of facial nerve function or hearing. That is picture. That is case 77 years old woman. She had surgery, partial resection 7 years before, and now she has recurrence of tumor with that's not a good picture, unfortunately, but that is tumors, large tumors, more than 3 centimeter in diameter, and cystic parts as well. Now, my personal opinion is that in this case, we talked before also, this is on the first, in this case, have to resect partial, especially cystic parts of the tumors, and then cyberknife. No, this is case for discussion. Conclusions. Surgical removal, open surgery, is a method, nowadays is a method of choice for vestibular schwannomas treatment. Large vestibular schwannomas require complex treatment, surgery, and radiosurgery. And neurosurgeons and radiologists, radio-oncologists have to work in a team to get the better results of this schwannoma treatment. Thank you very much.